I fully recognize that this is not what most people think of physical therapy. But it is the future of physical therapy. And if you don't want to agree with that or move on with that in some capacity, then I'm sorry, but we're moving on without you.
Welcome back to In the ED Now, a podcast that makes you an excellent physical therapist in the emergency department. I'm your host, Dr. Rebecca Griffith, the ED DPT. Today, we're going to talk to Dr. Katie Albright, whose focus is on primary care physical therapy. What she'll talk to you about today and what you'll be able to take home from this episode are: what is primary care physical therapy? Is it a practice setting? Is it a mindset? Is it an approach? Listen and find out. You'll also find out best strategies for communication of your findings, for how and when to refer patients for different conditions, and how you can take this practice and apply it in the emergency department setting. I hope you'll tune in the ED Now. All right, welcome to the show, Dr. Albright. It's so nice to have you. You're in the ED Now. Welcome.
Thank you. Glad to be here.
I'm so glad to have you. And I have loved having conversations with you in the past because there's some overlap between what we do. So can you tell people a little bit about yourself and how you got to where you are?
Yeah. So in a nutshell, I started out my career 9 years ago now. And my very first job out of PT school was, I was active duty Army, and my very first assignment was in a soldier-centered medical home. I got to my first assignment, and my boss, for whatever reason, just decided that I was ready to go into the primary care clinic. And so he moved me over there, and it actually ended up being so perfect and just exactly what I needed. And it was the perfect space for me to sort of flex my muscle in what I learned in school on differential diagnosis and management best practice, where one of the things that, so before I get into that, so now I served in the Army for a little while, and then I worked in an outpatient cancer center, which was awesome because I went from all my stuff in my musculoskeletal residency and orthopedic clinical specialization into a totally different population, or really just taking my knowledge, what I learned there, and expanding it to ensure that I was addressing all of the other body systems that are affected by cancer. So I went from there to a private practice that was a team-based sports medicine clinic. And then I started my own cash-based practice, and then COVID happened and blew everything up in my world. So now I am the owner of Redefine Health Education, and we have the mission of getting more physical therapists confident and competent in the area of primary care practice, and also just teaching people how and why it's important to have a physical therapist as a part of your primary care team, and just how to go about implementing that as an operation in any sort of healthcare facility.
So for people who are listening and they're like, what are you talking about? Like, what is primary care physical therapy? Because I get that all the time, right? Like, you work in the emergency department. Like, what do you even do? So what is a primary care PT?
Good question. So I'm also currently the education chair for the primary care special interest group, which currently is housed under the APTA Federal. But we are working on some inter-SIG collaborations with other SIGs, like the vestibular SIG and the imaging SIG. We're trying to do more cross collaboration between our SIGs because there's just so much overlap in what we do. But one of the things that we have really focused on lately is a clinical specialization, so a board certification for primary care. Mm-hmm. And as a part of that process, you have to go through and do an ABPTS petition to come up with the clinical specialization. And part of that is defining the scope of practice.
Yeah.
And so the scope of practice for a primary care physical therapist is a little different from what you might think, because some people assume that primary care PT just means, you can see a patient direct access. Which seeing a patient direct access just means you can see them without a referral.
Correct.
It doesn't necessarily mean that you are taking ownership or taking responsibility of what a primary care physical therapist actually does. So without reading the full definition, in a nutshell, it's basically a primary care PT takes responsibility for all patients' medical conditions that they present with from a functional standpoint. So I am not saying a primary care physical therapist does not ever replace a primary care physician or provider. We serve as a member of the team to help support them in everything that they're doing for that patient. And we also consult on and provide our input on what we think is best for their function. So, for example, if a patient has, if a patient comes into their primary care physician with low back pain, and they also have hypertension, and they also have, diabetes and those types of things. When the primary care physician brings us in as the primary care PT, we're not just addressing just that low back pain. We are also making sure that we are including um, the medical screening components that go along with the cardiovascular ramifications of hypertension and diabetes. But we are also educating them on how exercise and how lifestyle modification can help to optimize not only their medical conditions that they're dealing with, but also how all of it sort of relates back together. We know that individuals with low back pain often have multimorbidity. And it's really important for the primary care PT to be able to put all of those pieces together from a screening picture and a risk picture, but also for the patient to be able to educate them on how, all of these things are tied together. And we're really there to establish a more long-term relationship with the patient, just like they would have with a primary care physician. So the primary care PT moves away from the episodic model where it's like, oh, I have shoulder pain, I'll go to PT because I have shoulder pain. Instead of just focusing on that patient's shoulder, you're also considering all of their other, their entire complete health picture, and certainly helping them with their shoulder problem and their musculoskeletal problem, but then also like tracking them over time and developing a relationship with them and making sure that that you're aware of the social impact and the psychological impact that their health picture has on their future stability, on their prognosis, on this and that. And then you really are making sure that you have ownership, or you are acknowledging and accepting responsibility of being part of that patient's primary care team. So I fully recognize that this is not what most people think of physical therapy. But it is the future of physical therapy. And if you don't want to agree with that or move on with that in some capacity, then I'm sorry, but we're moving on without you.
I mean, I think that makes sense. So one of the things that I talk about a lot of the time is that as doctors of physical therapy, we need to manage our patients' care, not be technicians in our patients' care. And I think that historically, like you said, with that episodic care model, like, you're here, I'm going to fix your shoulder pain with these technical skills, I'm going to use my goniometer, and I'm going to get the TheraBand, and I'm going to maybe do some joint mobilizations, and I'm going to ignore the fact that you maybe have frozen shoulder from diabetes, from a different metabolic disorder, from a trauma that was caused to you by a violent partner in your home. Like, I'm going to pretend like your shoulder lives in isolation. And that's not really how we become doctors of physical therapy. That's not really how we transform society. And that's not how we make our patients better. And I love what you said about not discharging patients and building relationships, because I think that's one of the best things we can do for physical therapy and for the healthcare system. So if I have a healthcare issue, like, I'm like, gosh, I'm having back pain, who am I going to call? Like, I don't even know who to call. Maybe I'll call my primary care doctor, but what are they going to maybe tell me? They're going to say, oh, well, maybe just put a hot pack on it. But if I can call my primary physical therapist and be like, Katie, like, I don't know what to do. My back really hurts. And then you can help me triage what to do and what those next best steps are. And I know that I have somebody that's going to partner with me over the long term to mitigate this issue, to prevent it from happening again, and to make sure I can continue living my life. To me, that sounds like an excellent model.
Yeah, it's a pretty darn good model, especially considering that a lot of pain complaints from an orthopedic perspective, a lot of pain complaints are recurrent. We know this. We know that neck pain and back pain and other types of other types of pain complaints, from whether it's past injuries or just the way your body is, these things are recurrent. And I actually had a student who was asking me the question of like, oh, well, we saw this patient a year ago for low back pain and it helped. The episode of therapy helped for his low back pain then. And he's coming back a year later now with the same complaint. Like, what do we do? And I was like, well, if it helped then, it's probably going to help now too. And you're there to, I despise, and I have always despised this concept of like, we have to have an initial evaluation and then we have to have a plan of care and then we have to go through the plan of care and then we have to discharge the patient. And then when a new episode of care starts, we have to get a new referral, blah, 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 blah. I get it. I understand that like jurisdictional board requirements, practice act, blah, blah, blah. And I also understand like the insurance piece of it too. But like, we need to get a grip on what we currently have and recognize that it's not working for the vast majority of people, physical therapists and patients alike. It is not working. Okay. It doesn't make any sense that we should not consider a patient's past medical history and develop a relationship with them over time so that we can continue to help them. We know what their risk factors are going to be. We know that there are certain factors that predict certain types of illnesses or certain types of injuries. We know all of these things. It makes no sense that we exist on an episodic model. None whatsoever.
I totally agree with you.
Yeah, I can't. I just cannot anymore. And I will not, like, I just can't hold back on this concept about how, okay, even if an insurance is going to require you to, go through the motions, okay, you only have the shoulder pain diagnosis code, yada, yada, yada. Okay, great. Awesome. That does not mean that the previous time you saw the patient or the next time that you see the patient, that you can't carry the information that you know about this patient forward.
Right.
Okay. So like maybe it looks like an episode of care, quote unquote, on paper, and that's what it is. But you are developing a relationship with a patient, and when you quote, discharge them for insurance purposes or whatever you have to do per your facility or whatever you have to do, you are, and you're not telling the patient, oh, today's your discharge day. You're done with therapy. You graduate. It's, hey, my door is always open. I'm your doctor of physical therapy. And if you have any trouble with your function, with your physical function, with pain, I just want you to know that my door is open. You can always call me. You can come back to see me. And I am going to be here for you because I already know your medical history and I know you're this and that. And we will work great together for years to come. Like, why not?
Why not? I often tell people, like, the goal of physical therapy is for you to not need me.
Totally.
But I'm 100% here when you do need me. And I think it's different, like, this is probably maybe a tangent, but like when I talk to patients about their relationship with their chiropractors, they will see their chiropractor for anything, anything. And I mean, anything. Like I have a weird mole, I'm going to the chiropractor. And it's like this relationship. And I see patients, like, if you've been on any Facebook group where somebody's like, I have low back pain, what should I do? All these people are in the comments like, I love my chiropractor. I've been going to them for 27 years. And part of me is like, why do you still need them for this same issue if you've been going for 27 years? But at the same time, the other part of me is like, they have a relationship, they have trust, they're getting something out of that interaction, and it's valuable to them, that relationship. So just to take us in another direction, if people are listening and they practice in the emergency department, they're like, sounds cool. How does this apply to me?
Yeah. So there is a lot of overlap in our ability to medically screen, triage, and be able to make referral decisions. Okay. There's a ton of overlap there.
Completely.
There's a difference. So I'll start with the differences and then we'll come back to the, how is it similar and where is the overlap?
Perfect.
The difference would be in primary care, there is a continuous, sustainable, hopefully long-term relationship with your patients. In the ED, hopefully it is not that way.
No, I tell people I hope I never see them again. I'm like, this is the one area of healthcare where we do not wish to have repeat business.
Right. Primary care should be responsible. And I'm not referring just to physical therapy. I'm definitely referring more to the way that the American Academy of Family Physicians describes this is that it should be primary care, whether you're a pediatrician, a geriatrician, an internal medicine physician, family medicine, whatever, primary care should be able to manage the vast majority of your common health concerns and complaints, and be able to track your be able to promote health and be able to identify risk factors through across the lifespan. Okay. So whereas emergency department care is really just there for emergencies.
Ideally.
But again, with that being said, in emergency care and primary care, we both need to be practicing at the top of our scope, wink, wink, because of your butt.
Soapbox, yeah.
We both need to be practicing at the top of our scope when it comes to medically screening and triaging. So
Yeah.
the process of evaluation and determining what the problem is, determining your differential diagnosis should be no different. Because if you're seeing a patient for the first time in the emergency department, usually they're going to be seeing you for something that's very severe or appears or seems to be emergent, or somebody sent them there because they thought it was an emergency.
Yeah, or they didn't know where to go and had no other options.
Right. And in primary care, hopefully it's not quite that, but it could be, So our role, whether you're in the ED or whether you're in primary care, is to do the best possible service that you can for that patient. And that includes comprehensive evaluation of all systems. Okay. So if somebody comes in with neck pain, okay, like, was there trauma? Was there a mechanism of injury? Have you had this ever in the past? Are you having neurologic symptoms? Are you having cardiac event? Are you having a pulmonary event? Are you having this and that? So we need to be able to identify and understand referral patterns, and just be at the best of our ability with pattern recognition in general, and not just from a musculoskeletal standpoint.
Yes.
I think PTs, especially in the outpatient ortho world, forget that we are foundationally and fundamentally trained in all body systems. There are PTs who primarily treat cardiovascular and pulmonary conditions.
Many at my hospital. We have the most cardiopulmonary specialists in the state.
Yeah, and that's awesome. And I think that there's just a lack of emphasis on that, especially in the orthopedic space. But yeah, so like when it comes to foundational differential diagnosis workup, the process is going to be the same. Now, one of the things that I really harp on, I teach a course in foundations for the primary care therapist, but one thing that is very similar for really anybody, whether you consider yourself a primary care therapist or not, is the concept of referral decision making. So if somebody presents with X and it looks like X or it looks like Y, they have all of these variables that they're presenting with, what do you do? Because I think that a lot of PTs understand when to identify a quote unquote red flag, which I hate that. I hate the terminology, but it's there. The terminology makes people think that something is or belongs in the emergency department, when really it could just be something that might be what I call non-critical medical, where it needs the involvement of another healthcare professional, but the urgency is not such that it needs to be taken. It can be routine.
Yes.
They can be seen within the next 2 weeks and it would be fine. Versus, okay, and this is my biggest issue, cancer. People think that cancer is a red flag. Okay, I understand that when we suspect some sort of malignant process in a patient, yes, we should 100% be referring a patient if that is the case. Does a patient who you suspect cancer with belong in the ED? No. 100% no, because most cancers, you're not actively dying right now. If they have unstable vitals, or like you mentioned before, I loved that, the altered mental status, those types of things, then they belong in the ED.
Or like massive neurological compromise. Like, please send them on in. But yeah, like if it's a suspicious mole, please don't.
Correct. Or if, even if there's a finding on imaging. So I've run into this
Yep.
before. And in fact, when I was active duty military, I had a patient in his late 30s who had a large, unfortunately, a large osteolytic lesion in his ilium. And then, we did some additional imaging, and he had more. He had Mets in a lot of places. And at that time, I was like, what am I supposed to do with this? Does this need to be seen today? Does it need to be seen tomorrow? Is it okay if we wait 2 weeks? Like, what am I supposed to do with this? So in my course, I really focus on teaching decision making when it comes
Mhm.
to different case presentations. Because cervical myelopathy is not cervical myelopathy is not cervical myelopathy. There is a
Can confirm.
spectrum. There's a spectrum of presentation. And
Yes.
that's very similar for a lot of other conditions that we all just think are these quote red flags.
Yeah, if you're walking into an outpatient clinic with cervical myelopathy, you probably don't need to go to the ED today.
100%.
Now, if you can't stand up in the clinic
Yeah.
from cervical myelopathy,
Yeah.
please also don't ask that person to drive themselves.
Yeah. Thank you. And
So,
yes,
so
yes.
what's
All
like
the things.
so if we're doing this, we're taking this systematic, systems-based approach to looking at our patients in the emergency department. Because one thing I say to students is just because we're seeing this patient doesn't mean the diagnosis is complete. We're part of that diagnostic workup, which is part of being that team.
Mhm.
And it doesn't mean there also isn't an emergency or that the emergency is over. I've had way more incidents occur in the emergency department than in the ICU because the ICU is so tightly controlled and the workup's primarily done. Like they know what's happening, they know how to mitigate that. But in the emergency department, we're still in discovery mode. We're like
Mhm.
paleontologists, like wiping the dirt off of the fossils to figure out what's underneath it. So how do we, once we've done that, like kind of figured out some things and maybe they truly are red flags, based on your experience in this primary care model, how do we best communicate that in an appropriate professional way with the appropriate amount of urgency to our medical team so we're not
Mhm.
alarmist?
Mhm.
Because we want to be trusted, right? Like I need to, when I go tell a physician something, I need them to listen. And if every time I'm like, the sky is falling in room 5, they're going to stop listening to me. But
Mhm.
if I can communicate appropriately, that patient's going to need to get the care that they need every time. So what do you suggest?
Great question. So this is another section in my course that I cover on interdisciplinary communication and how and when and why to communicate. When you need to just send an email, when you need to pick up the phone, when you need to pick up the phone and leave a message versus wait on hold. When you need to, you know, quickly write out a note and maybe in some instances and I actually would be wondering what your opinion of this particular case is because we talked on my podcast episode on a case of DVT versus PE and like
Mhm.
when to call an ambulance versus when to like okay the patient's husband is in the waiting room, can that person, are they stable enough to like make the 5-minute drive to the ED or do they need EMS to be here right now? There are some cases like that where I still struggle a little bit, but and now I'm like forgetting what communication. So like when can you just write out a quick note, say what your concerns are, have the patient like go to the ED or go to wherever they need to go, urgent care, like, hey, if it's a wrist fracture, can they go to ortho urgent care 2 doors down and like they'll be fine? Yeah, like you can split their wrist. They can walk their little selves down to get a radiograph because that's what's needed if you
Yeah.
suspect that. Or do they need to urgently like go by ambulance to the emergency department? So like those are the two areas where I struggle sometimes because on a textbook from a textbook standpoint, it's like I should have they should go to the ED by ambulance like almost every time. But from an actual like life application, it becomes a little bit more challenging. But I
Well,
do
especially
have
with our healthcare system, right? Like patients are going to be like, I'm not paying for that. That's an expensive cab ride.
that's what I have come up against time and time again. In fact, I did have a patient with a suspected PE postoperatively. Um, she refused. She did have a rapid pulse. She wasn't, diaphoretic, breathing super heavy. She was slightly short of breath when she was moving around with her walker. And I noticed that she had a rapid pulse and her blood pressure was elevated compared to baseline and all of that. But she was like, no, I'm not. No, she didn't even want
Not
to go to
doing
the
it.
emergency department in the first place. And so she was like, all right, I'll call my husband, like blah, blah. So her husband came and got her and drove her. And like, was that the wrong thing for me to do at the time? Like, at least she got to the ED and was diagnosed with a PE and was, medically managed. Sometimes there's hardship there because there's ways that you would approach it from a textbook standpoint, but then there's life. And then there's like, oh, are you going to pick up? Like, I would recommend that you call and wait on hold to talk to somebody about this.
Mm-hmm.
In the best of your abilities, you please do that. But there are those instances where you might be waiting for hours, or you might be waiting for an outpatient provider like a primary care physician or a cardiologist or whatever to call you back, and you never get the call back. Are you going to have the patient wait there for 8 hours? Or are you going to, like, what are you going to do? So there's lots of like problem solving that I try to do in this course. And I love the live courses, especially because this is where a lot of discussion is stimulated.
Mm-hmm.
And I don't necessarily think that there is one hard and fast way that everything always has to be done. But I think the problem solving and understanding all of the different scenarios is really helpful to work through.
So in the ED, right? Like, I'm going to come out of that room and I've got that provider face to face.
That's so nice.
Oh, it's amazing. So what are your best strategies for like giving the information succinctly, clearly, and then have that result in action taken?
Mm-hmm. Yeah. So there's I teach the S-bar method, which is a
Same.
really commonly accepted. It was fundamentally designed in the nursing profession, which is awesome. So the S-bar method is basically where you're giving your assessment. You're just giving like a super brief statement on the background. So the situation, what's happening. And then, so that's the S, the B is the background. The A is your assessment of what you think is happening. And the R is your recommendation. Now, I also include a plus with that. And the plus from my perspective is, state your role in this problem, and then give your contact information and make sure that that other provider knows that you're available and that you are wanting follow-up on this patient after the fact. Because I think sometimes that's not expected of a physical therapist. But if we're going to be following up with that patient, we need to know what happens in the meantime. So I use the S-bar method, and it's something quick. It's like, let's say I'm picking up the phone and I'm in a state where I can't place an order for radiographs, which I think in 2023 is the most insane thing that there are.
Yeah, totally different soapbox, right?
It's insane. Yeah, very different soapbox. But so I'm in a state where, okay, maybe that's actually in the regulations, like not allowed. And I have to call somebody in order to do this. And I know that they are presenting, they had a, fall on an outstretched arm and they meet all the criteria and yada, yada, yada. So I call and I say, hey, I have your patient here. 65-year-old, Donna Jameson. I'm just coming up with this name.
That sounds like a Real Housewife's name.
Yeah, that's Donna Jameson. That's
Donna
a good
James
one.
from Atlanta.
And she fell on her wrist. She's point tender. It's swollen. She's having difficulty moving. I believe that she needs a radiograph. And because I am concerned for fracture, I would recommend starting with this set of radiographs done, based on, okay, do you think it's the scaphoid? Do you think it's the metacarpal? There are different views of films that are important to include, because if you just order standard radiographs on anything that comes through the door, you're going to miss stuff. So you should know that. So, and then give your recommendation. My biggest pet peeve in all of therapy practice, or just any practice in general, is like, oh, if we identify something, just refer back to primary care, tell the patient to go back to primary care. And it's like, and then what? Primary care physicians and providers are probably the most overloaded and overworked and overburdened population of healthcare professionals in the healthcare field right now.
Yeah, and they can't do it all.
No, they cannot do it all. And it is our responsibility to communicate findings and to help them. And so if you have a specific recommendation, like I at one point had a patient that I was concerned had MS. Like it was kind of declaring itself almost like on a, the a stepwise as I was working with this patient. And I was like, I am not diagnosing a patient with MS, but I called and I said, said all my findings. I gave, some of the supporting, the supporting findings from my evaluation and from my time in working with this patient. And I said, I'm concerned about something progressive. This really looks like MS. Would you, mind working this patient up? And, what are your thoughts? Seeking out their opinion too. And I have never gotten anything other than like, thank you. That is
Yeah.
very much appreciated. Like, thank you for this communication. We'll definitely take care of this patient.
And I think sometimes the best way to approach that is from my evaluation, assessing this, this, and this. These are the things that concern me, and I think a workup for this diagnosis may be indicated. Because I'm not, like you said, I'm not diagnosing MS,
Mm-hmm.
but I am diagnosing a dysfunction
Mm-hmm.
that looks a lot like it would come from something like that. And we do look at things differently from patients. And I did have a case in the emergency department with a patient who was there for, like, she fell kind of, but like off a step ladder. Like, it was not a unique way of falling, but she felt like her leg just like went dead. And like when she stepped down and it didn't go well, she wasn't hurt. She just felt very alarmed by the fact that her leg sort of pieced out in the middle of a functional task. She was my age. She came to the emergency department. Her family was a lot more concerned about it than she was. The doctor that does this like 5-minute triage was like, hey, like, if you weren't here, I would just discharge this patient. But since you're here, can you just take a look? Like, she's really concerned about this leg. I did the most thorough neurological examination of my life, and I am an NCS, so that's saying something, because it was like those spidey senses that felt like there was something wrong, but I couldn't find it. And so everything was just like not quite right, but not quite clear either. Like, she was not declaring herself. Like, she'd inch up to the line and then be like, just kidding, and it
Mm-hmm.
was fine. And so at the end, my bottom line was, there is not an emergent condition happening. You're not indicated for any advanced imaging today, but these are things that, like, I just want you to keep an eye out for. And so I think those return precautions in any kind of physical therapy situation are also important. Like, these are things I want you to watch out for. And she did. She actually came back 24 hours later because things progressed. Like, she was like right at that tipping point, and she came back for those return precautions and ended up getting a full workup. And she had, maybe the largest white matter burden I've ever seen on imaging
Wow.
before. And her functional presentation, again, like we know, did not correlate to what we were seeing on the imaging. And she did get the outpatient care that she needed set up after that point. Again, like, was MS in this particular case an emergency even that second time? No. But I think we have that ability to look at things from a different perspective than other providers do, because we can see that functional nuance. We could see that, like, that single leg stance on that other side is just not quite the same.
Mm-hmm.
There's just something not quite right. Like, her reaction time's not quite right. Like, it's just not quite right. And I think we need to trust our gut with that as well. So in that case, for me, that was an evaluate, treat, and refer. And I set her up with a neuro PT a little bit down the road. And I was like, hey, if these symptoms just don't respond, I want you to see this person. So I think you're absolutely right that sometimes we may be that person, but we have to communicate it in a different way and get the patient the care that they need.
Mm-hmm. Yeah. Couldn't agree more. Couldn't agree more.
So if people are listening, how do they find you so that they can get this primary care mindset, they can get this primary care tool set, and they can kind of level up their practice? Because my hope is that people who are hearing this are like, no matter what setting I'm in, I want to practice at this level.
Yeah, I'm pretty easy to find. You can go to my website, www.redefinehealthed.com. I'm also on all the social media platforms at Redefine Health Ed. And it's redefined with no D at the end. That's a common misconception. The only social media that doesn't have that is Twitter. And on Twitter, I'm Redefine Con Ed, so CONED. Or you can just email me, info@redefinehealthed.com. I've got a YouTube page. You just kind of type those words into Google and you'll be able to find me. And I am more than happy to have discussions with people, with PTs, with rehab professionals, with administrators, with anybody that's interested in primary care PT, and even, you know, physicians that are looking to include a PT as part of their primary care or specialty care team, because a lot of that is becoming more team-based care is on the horizon, and it's the way of the future. I wish it was the way of the now and the past, but you know, coming where we came from in, you know, paternalistic medicine, that is not exactly where it came from, but it is definitely where we're headed. So I'm really passionate about it, really open to talking to anybody who wants to talk about it. So thank you so much for this platform. If people are interested more in clinical skills, we have 3 different course offerings and more to come. The first is Foundations for the Primary Care Therapist, and that is an in-person and or online course. And that is available now. I just launched the online course last week, which is cool. And in fact, there are, well, I won't announce that quite yet. It's not there are more things on the horizon, but we also have a musculoskeletal imaging certification, which is,
EDPTs. Pay attention to that.
oh my
Those
gosh, huge.
super high value if you're practicing in the ED.
Super high value because if you don't know how to use imaging appropriately and what studies to order for what types of cases, you will miss things. No doubt.
Or even how to look at them, right?
Correct.
Like, what do you do with it when, like, you've ordered it? What do you do next?
Exactly. So one of the modules within the certification is clinical response to imaging findings. So that you know how exactly to look at an imaging study, and then built into the body region specific modules, you know, this is the given pathology, this is the common imaging, these are the cases. Let's look at them. Let's figure out how to scroll through an MRI and a CT and like, oh, there's the thing that we're looking for. And how to, you know, review reports and understand the terminology and then communicate with radiologists and other healthcare professionals and the patient. It's all very important. And it's just such a thing that is so misunderstood and misutilized. And then we also have a recognizing rheumatology course, which I think in the orthopedic world is really important, and rheumatologic conditions often go undiagnosed for years. So it's awesome if you ever have a patient with a rheumatologic presentation. If you can help them identify it, it will save them years of pain and struggle. So
I love that.
Yeah, come visit our website and find out more about all those courses. And we have several more that are cooking. So be on the lookout.
All right, final soapbox. Tell us what's on your mind.
Honestly, the thing that is on my mind right now is the fact that it's sunny outside. And I just planted all of these. This is, if you asked, so I'm telling you.
Tell me.
I planted all of these different veggies and flowers, like they started in my kitchen. And it has been raining and hailing and doing crazy things here in Chicagoland. And this weekend is supposed to be very beautiful and sunny. So I'm really looking forward to getting all my stuff transplanted outside and just enjoying, finally, like, spring is here. That's really what's on my mind right now. I'm sure you were thinking maybe I would say something about physical therapy, but
yeah, nope. I mean, just a little. But here's the thing. Everybody who's in Colorado who is listening to you like this is like, that's a huge mistake. You don't plant until after Mother's Day. So yesterday it was 20 degrees. There was snow and ice on the road. Today it is 50 degrees, sunny. Everything is green. You'd never know that there was snow yesterday. It'll be 80 degrees this weekend. I cannot wait. So I'm with you. I'm all about that. Let's get some vitamin D this weekend.
100%. 100%.
Thank you so much for being with us. This is Dr. Katie Albright. You are in the ED now, and you're officially discharged.
Thank you.
Thank you for listening. In the ED Now is a podcast hosted and produced by Rebecca Griffith, the ED DPT, as part of Rebecca Griffith Physical Therapy, LLC. Our podcast makes you an excellent emergency department physical therapist. This podcast is intended for educational use only and is not intended as clinical or medical advice. While we make every effort for accuracy, factual errors may be present. Since you've been in the ED, I'm prepared to give you your discharge instructions. Please subscribe, share, and find more at the eddpt.com. You're officially discharged.